Okay, guys, we're starting on chapter 16. We're getting into the meat of what we're going to talk about. This is pregnancies that are at risk. These are things that complicate pregnancy. This is going to be long. It's 59 slides, so you might need to take a break about halfway through, listen to a little bit of it, and come back and listen to it, because there's a lot. There's a lot of stuff. So bear with me. We'll get through it. Take a break anytime you want to. So here we go. So pregnancies at risk. Now, in the past, a lot of women had chronic conditions and they weren't really able to have babies. Now, in the society that we live in, a lot of moms that have complications are able to deliver healthy term babies. So these moms still have these complications, but we're delivering healthy babies, or maybe we're delivering babies that have some complications afterwards because of what complications mom had. So with all the new stuff, now we got lots of new things that are available to our moms. So anything that can complicate these things is any medical condition, and pregnancy complication can be a risk factor, and they can be interrelated with pregnancy. Pregnancy can, if you already have an underlying condition, pregnancy can make that worse. So we need to let moms know that. If you got gestational diabetes, pregnancy is probably going to make that worse. If you have a heart condition, it's probably going to make that worse. If you have hyperthyroidism, probably going to make that worse. All these things are going to make things worse with the pregnancy. So these things can also change the outcome of our pregnancy. So all of these things can also change and affect our fetus adversely. So that's why prenatal visits are going to be very, very important. Sometimes if you have a mom that has all these complications, we end up seeing them, we said for the first, we see them for a month up to 32 weeks. These moms might be seen every 2 weeks in the early on, just to make sure that they're doing okay. First thing we're going to talk about, hyperemesis gravidarum. This is what we've talked about in prenatal. This is different than just some nausea and vomiting. This is severe nausea and vomiting. These moms are going to lose weight. They're going to have nutritional deficits, and they're going to have electrolyte imbalances. How are we going to know they have these things? We're going to look at their blood work. So we're going to weigh that mom on her first prenatal visit. This mom weighs 120 pounds. She comes back and she's 110. Her protein levels are low. Her electrolytes are all out of whack. Her specific gravity on her urine is high. All of those things are going to be indicative of hyperemesis gravidarum. This can affect the way our babies are going to grow. It can reduce the nutrients, oxygen, and blood to our babies. So our babies could have they could have that intrauterine growth restriction. So these are how the moms are going to come in. They're going to come in dehydrated. They're going to have excessive vomiting. They're going to have weight loss. The big difference between your normal nausea and vomiting and your normal morning sickness, these moms will have electrolyte disturbances. These moms will have nutritional disturbances. So these are going to be different than just your moms that have nausea and vomiting. So what are we going to look for these moms? If we know they have electrolyte disturbances, we're going to have to draw their electrolytes. If we know they're going to have dry or dehydration, we're going to have to look at their urine, make sure that their urine is good, make sure that they're not breaking down their fat. So we're going to look at ketones in their urine. A lot of times they'll have elevated liver enzymes. Treatment, strict I&O. We want to make sure what is coming in, what is going out. Make sure you check their vital signs, check their weight frequently. A lot of these moms are going to end up with IV therapy. So we're going to tell these moms to eat very, very small, frequent meals. Don't drink a lot of fluids during their meals, because we want them to actually get the nutrients, not the fluids. Progress their diet as tolerated. Ginger has been known to help a little bit. There is a vitamin B6. I would not tell my moms to get it unless it was advised by the doctor, but it's pyroxidine. And sometimes vitamin D6 can help. Sometimes we will give them medications to help. Sometimes I've seen them give metoclopramine, which is Reglan. I've seen them give some Zofran. It depends on how bad it is and how they can treat it. Less medication, best fetus. Diabetes mellitus. This is a huge one. How many times do you go to your clinicals and probably 4 out of 10 patients have diabetes? So these patients also can have diabetes and be pregnant. So there's a lot of complications there. So if you have a mom that is type 1, that means her pancreas does not work at all. She has been a type 1 diabetic all of her life. Now, we have other kinds that are type 2. Those were the ones where type 2 is the pancreas works, it just doesn't work good enough. So we can have type 2, or they can get gestational diabetes where they get that insulin resistance. And treatment is going to depend on what it is. So during pregnancy, we're gonna look at their sugars continually throughout their pregnancy, and we're also going to have to monitor babies very closely after pregnancy. So pre-gestational diabetes, pre-gestational. So these are the moms that have no insulin being produced. These are the moms that have a history of a poor outcomes in the past. Our moms that were insulin dependent years ago had a lot of miscarriages. They had a lot of fetal abnormalities. They had a lot of poor outcomes. Now, with what we're doing now, we're able to keep these moms much more under control. So our biggest things with our moms that had type 1 is improving that glycemic control. We need to make sure that their blood sugars stay in control, and make sure we watch that baby, make sure we watch that mom. We don't want her going from a blood sugar of 60 to a blood sugar of 500, 6,500, 6,500. That is going to give us a poor outcome with our baby and our mama. We need them to have strict blood glucose control. So we need them to have a good range in their blood glucose. That means they need to be monitoring their blood glucose 3 times a day and at bedtime, and taking insulin accordingly. If it's poorly controlled, we know that these babies can be born with birth defects, stillborn, increases mom's risk for hypertensive disorders, polyhydramnios, which means that they have too much amniotic fluid, preterm delivery, and most of the time these babies are big because they've been on a sugar train. They have been getting cotton candy for a long time. So mom's blood sugars have been 300. Who else's blood sugars are 300? That's a baby. So baby is packing on the pounds, and so we're going to have big babies. So our delivery is going to be difficult. Now, gestational diabetes. This is where it's similar to type 2, but it occurs just during pregnancy. Risk factors. So these are things that can be risk in our babies. These a lot of times, if the mom has a history of a large gestational infant, so let's say that mom's previous baby was 10 pounds, that kind of makes us start thinking, oh, I wonder if mom had gestational diabetes. If they have a gestational diabetes mellitus before, if they've had a fetal demise, if they're over 35, if they have a history of type 2 in their family, if they're obese, if they're over 200 pounds, that's going to increase their risk for gestational diabetes. Non-Caucasian ethnicity is going to increase their risk for that. If they have a fasting blood glucose over 140 or a random over 200, that's going to increase their risk. We're going to have to really go back and look at that and start doing some more testing to find out what's going on with them. A lot of these moms that have gestational diabetes have no symptoms whatsoever. They don't have any of the polys. They don't have polydipsia, polyuria, polyphagia. They don't have any of that. But they come in, every mom will get screened at 20 to 28 weeks. They're going to get screened. So we do know that if mom has a history of gestational diabetes, it does increase her risk of developing type 2 later on down in her history. So, fetal complications. We've already talked about fetal complications. These are things that can happen to our babies. They can have increase for placenta issues. I'm not really sure what the pathophysiology is for that. It's probably just damage to the placenta from having that large sugar content all the time. And then moms develop the fetal hypertension, and that constricts some of those vessels. So that's why I'm saying we have placental issues. That placental issues changes the growth, and so our babies aren't growing, or changes the growth of them. So we might have babies, a lot of times will have hypoglycemia after birth. Most of the time, if your mom's had gestational diabetes, every baby will get a blood glucose an hour after birth, because again, they've been on a sugar train, and now the sugar train has come to a halt after delivery. So we're going to be looking at that. A lot of times these babies are really big. So you might have a baby that's 37 weeks and they're 8 pounds 9 ounces, and you think, oh, we got a great baby, we got a good baby, but their lungs are really immature. So they will have more problems with respiratory things afterwards. And a lot of times when they have problems, sometimes that can actually increase their risk factors later on in their life for health concerns. Many times these babies end up being a C-section because they're too big. So macrosomia just means that we're bigger. So these babies are greater than 4,000 grams, which is 8.8 pounds. Now you can have a normal baby that doesn't have gestational diabetes that's still 8.8 pounds. But with a mom, if you get a mom that has an 8.8 pound baby, that would be something that we would be thinking about. How do we screen for gestational diabetes? Well, first of all, we do a 1 hour glucose tolerance test. So we load mama up with lots of glucose, and it's usually done at 24 to 28 weeks. We load them up, we check their blood glucose an hour later. If their blood glucose is 130 to 140, that's going to be considered positive. And then we're going to have to go on to the next test. So the next test, the moms are going to have to fast. No caffeine, no smoking for 12 hours. We're going to give them a glucose load. So we're going to load them up again. Then we're going to check their sugars at 1, 2, and 3 hours. This is called a 3-hour glucose tolerance test. If they fail that one, they are considered now diagnostic for gestational diabetes. The 1 hour glucose tolerance is a screen. It's just a screen for it. The 3-hour glucose tolerance test is diagnostic for it. Now, if they get ketones in their urine, that is also a problem, because sometimes they don't have enough. When the sugar gets so high in the bloodstream, and their pancreas works, it just doesn't work enough. And so they end up continually having that high blood sugar. Their body is hungry, and that baby is hungry, so it starts to break down the fatty tissues and causes us to get ketoacidosis. So we look for those ketones in the blood on our moms that have gestational diabetes. So how do we treat, if we have a type 1 diabetic, or we have a mom who has a history of gestational diabetic, or we have a mom who's obese, or we have a mom that fits into those categories of pre-gestational diabetes, we're going to have them come in. They need to come in pre-pregnancy. They need to talk to their provider before they become pregnant. They need to make sure that they're getting everything under control. They need to make sure that they're getting good glycemic control before they get pregnant. So they need to make sure that they're checking their blood glucose every time they eat, at bedtime, and doing their insulin accordingly. If they're on a pump, make sure that their pump is working properly, make sure things are going right. They definitely need to take that multivitamin, and they definitely need to take their folic acid, because we know that that can be that can increase their risk for neurotube defect. So glycemic control with these moms is very, very important. So they're going to have to do lots of finger testing. They're not going to like it, but they're going to have to do it. We might do a hemoglobin A1C on our diabetic moms that have been tested positive, and now we know they got gestational diabetes. We might look back and see what their 3-month was. How well has that glycemic control been? Most of the moms that have gestational diabetes will be on insulin. Insulin gives us way better glycemic control than oral glycemic agents like metformin, anything like that. Metformin has been proven safe in pregnancy, but many of the other oral hypoglycemic agents are not considered safe in pregnancy, so we do not use them. So most of our moms will be placed on insulin because it gives us better and tighter glycemic control, so it makes our outcomes for pregnancy much, much better. So just know the difference between hypo and hyperglycemia. I think you guys probably already know all of that. Your mamas that are hypoglycemic. Ketoacidosis, your moms that have ketoacidosis is when their blood sugars are going to get up over 300. And their bodies are hungry, their babies are hungry, these moms are eating, they're thirsty, they're peeing a lot, and we got to make sure that we're looking for that kind of thing. So if we've got a mom in labor or a mom that went into preterm labor and we're giving her like tocolytics, that will increase their sugars or decrease their sugars. Corticosteroid use will increase their sugars. So insulin pumps that don't work increase their sugars. So if you got a mom that's 24 weeks and we've put her on terbutaline to stop her labor, that's going to cause her to have elevated blood glucose levels. So we might have to change her insulin levels to meet that need of that mom. Okay, so a mom that has type 1 diabetes, she has type 1. She was born with this, born with it, but at age 5, her pancreas just went kaput. This mom has to take insulin. She needs a diet and exercise, and we've got to watch that baby. So you can see the biggest thing here with this mom is insulin therapy. She has to take her insulin, she has to take it routinely, and she has to keep that glycemic control good. Then she has to look at her diet and make sure that she is eating a well-balanced diet and not carb loading all the time. Now, a mom that has gestational diabetes, our biggest thing with her is going to be her diet. She needs to change her diet. She needs to decrease, her carbs so her own body can take care of that with its pancreas. Now, sometimes the second tier, sometimes we have to add insulin to that. We want her to continue her exercise, and we're still going to do fetal surveillance. But that's the biggest difference here. If you're type 1, it's going to be insulin, glycemic control. 2 is going to be these moms need to eat good. They need to have a balanced diet. If we still can't keep it under control and we still can't keep glycemic control, then we're going to add some insulin to that. So how do we treat our moms that have type 1 or type 2? Fetal surveillance is going to be critical. These moms are probably going to get ultrasounds way more frequently. We're going to request that they get the maternal serum fetal alpha-fetoproteins. It's a screen. Remember, it's screening for neural tube defects. It's screening for chromosomal defects. We know these moms are more likely to have those types of things. We're going to look at their hemoglobin A1Cs. We're going to do, echocardiograms on mom, making sure that everything's okay. Non-stress tests on mom. Remember the non-stress tests? We want them to be reactive. Biophysical profiles. Remember the B? We want it to be above 8. Contraction tests. We want, the contraction test to be negative. So that's going to be what we're going to look for. Now, determining how we're going to deliver this baby. 1, we're going to look at that amniocentesis. Are their lungs developed? Are their lungs good? Sometimes we have to induce these moms. Make sure they got good fetal lung maturity. If not, it's going to be rough. Many times these babies don't deliver well because they're big. And so shoulder dystocia will be a problem. So we got to look for all of those complications. Treatment, most of the time these moms, I got a bug in my house. Most of the time these moms are going to be seen by an endocrinologist. They're going to have a perinatologist. They're going to have their obstetrician that's going to be helping with them. They're going to have a diabetic educator. They might have like a social worker that's helping make sure they're getting the right kind of foods that they need to have. So this approach is not going to be a one-man show. They're not going to get to just see their doctor. They're probably going to be seeing multiple doctors, multiple trips to the doctor. So pregnancy complications, moms a lot of times can develop hypertension. So every time they come to the doctor, they're going to need to have that blood pressure looked at, and we're going to have to really trend that blood pressure. Preeclampsia, always ask them, do you have a headache? Do you have any visual disturbances? Do you have any epigastric pain? Look for edema. Do they have edema in their hands, in their face? Look at their urine. Do they have protein? Do they have an elevated blood pressure? They might not have an elevated blood pressure. Maybe it's on the upper ends of blood pressure, but they've got the epigastric pain. They've got the headache. So start looking for those kinds of things and discussing that with the physician. So we're always going to look at our nursing process, ADPI, and make sure that we're making correct goals for that mom, and goals that can be measurable, goals that we can do, and goals that will have a good outcome. Some of our moms are going to have cardiovascular complications. Maybe this mom back in her young years had chemotherapy and it damaged her heart. So she has some heart complications. Maybe she was born with some heart complications. So we have to look at that. So common conditions that we might see would be coronary heart disease, pulmonary hypertension, congenital heart disease. So this would be a mom that was born with congenital heart disease. This might be a mom that took some medication that caused some pulmonary hypertension. So these moms, the biggest risk factors that we're going to see here is during that second trimester, during labor, and during that postpartum period. So those are going to be our times that we're really going to have to watch this mom very, very closely. Again, these moms need to come in before they decide to become pregnant and start making sure that they're healthy. They need to get their EKGs, they need to get their echocardiograms, they need to have their Doppler studies, they need to make sure that they're healthy before they go into pregnancy. So, signs and symptoms of a mom that might be having some cardiovascular issues. They might be complaining of some dyspnea, orthopnea. Maybe they can't lay down. Every time they lay down, they cough. If they're laying down and coughing, what could be in their lungs? They could have some pulmonary edema. Dizziness, fainting, chest pain, all of those kinds of things that they are going to complain of, subjective things. Objective data that we're going to see, maybe they have some cyanosis, maybe they got some clubbing of the fingers. Remember, clubbing of the fingers is usually due to chronic lack of oxygen, distended neck veins, tachycardia, murmurs, edema, all of that good kinds of stuff that we're going to look for. So treatment, it's going to depend on what they have. You know, which of the cardiovascular diseases do they have? And so our biggest thing is prevention. Detect it early and treat it early. Don't wait till they're in congestive heart failure to start treating it. So management during pregnancy, we're going to have to they're probably going to have more rest than somebody else. Look, monitor for any unusual stress. Make sure they're doing a good diet. They probably will have to have medications to probably get them through. Decrease their activity if they need to. Some of these moms might end up on bed rest at the end. Management during labor, don't put them in supine position. Keep them with their head up. And look at spontaneous versus a C-section. You know, which one's going to be the less risk? Analgesia. We don't want to give them a lot of analgesia, so we're going to have to monitor for that. Monitor for hemorrhage, frequent vital signs, cardiac monitoring. These moms are going to be at higher risk than your mom that just came in that doesn't have any of these complications. So nursing care for us, you're going to have to observe and report abnormal findings. Monitor for cardiac decompensation. That's going to be looking for your dyspnea, checking your pulse oximetry, looking at your blood pressure, checking your pulses, listening to their lung sounds, listening at the bases of their lungs, listening for the rails back there for maybe back up into the lungs. Protect them from any type of infection. Encourage proper positioning for sleep. Maybe they need to sleep sitting up. Maybe they need to sleep in a chair. Educate them on if they already have a cardiac problem and they're doing illicit drugs, that's going to increase the workload on the heart. It's going to decrease the positive outcome in the baby. Smoking, fetal surveillance, that's going to be our biophysical profiles. Remember Bio 8, kick counts. Closely observe these moms for cardiac decompensation because they can go into heart failure really, really quickly. So make sure we're monitoring for all of that. Now we're looking at anemia. What is anemia? Just when you look at anemia is anything that there is a blood deficient in red blood cells, hemoglobin, or total volume. So if we have a deficiency in a red blood cell, if we have a deficiency in a hemoglobin, or we have a total volume, there's three things there. So the main causes, blood loss is going to be your total volume. You're losing blood, so your total volume is down. Hemolysis is going to be your red blood cells. Let's look at our red blood cells. Hemolysis just means that they're bursting and they're not working like they should. Maybe we don't have good production of our red blood cells. So our production of red blood cells is going to be our hemoglobin. We're going to look at that. The most common one in pregnancy is iron deficiency anemia. Remember pica that we talked about? Mom has that unusual craving. So iron deficiency, these moms are going to need iron. Sometimes the moms might even have to come in for iron infusions, give them additional iron. These can complicate our other things that can complicate pregnancy are different types of anemia. We won't really talk about those. This is going to be our big one here. But megaloblastic anemia, pernicious anemia, sickle cell, thalassemia, all of those are going to be bad. But this is the one we're going to talk about because it's the most common that we're going to see in our moms. Iron deficiency means that we are not producing red blood cells. Or we're producing red blood cells, but they're tiny, they're microcytic. Hypochromic means that they don't have a lot of good color in them. They're not good in red. So because of lack of the iron. So we got to make sure that we're looking at all of those things. Common symptoms, the biggest thing you're going to see with your moms, they're going to be tired. They're going to be fatigued. They're going to have tachycardia because the body's trying to compensate and push that as much as we can. Tachypnea, can't get my breath because I don't have enough red blood cells to circulate. They're going to have dyspnea. They're going to be pale, hypotensive. They're going to be tired. They're going to be weak. They're just going to come in and have lots of symptoms. This is what we're associated with our pica. These are hemoglobin levels less than 11. Sometimes we will see moms with hemoglobins of 8. This mom's going to be really tired. She's not going to be able to go home and cook and clean and do a job with a hemoglobin of 8. So she's not going to feel good. She's going to be tachycardic, tachypnic, dyspnea, pale, weak, all of those kinds of things. So how are we going to treat it? We're going to tell her to increase her diet in iron and folate. So she needs to eat lots of good green leafy vegetables. Increase her vitamin C. Possibly she might have to do some iron injections. Sometimes they've had to do iron infusions while they're pregnant. So it just depends on how bad it gets. Make sure maybe we need to set them up with a dietitian to help them get those good diet choices. Constipation is going to be a problem here because we're giving them lots and lots of iron, so they're going to get really constipated. So how do we prevent that? Increase their fluids. All those kinds of things. Refer them for counseling. Sickle cell anemia, we will discuss this one because sickle cell anemia is a little bit more common of the anemias, but it is a genetic disorder where the hemoglobin are shaped abnormally. Instead of being shaped round, they're sickly, so they're kind of like sickle. They look like a little sickle. And sometimes, a lot of times, pregnancy can accentuate the sickle cell and cause them to have a sickle cell crisis. And these women are going to be at higher risk for renal dysfunction if they get sickled because those sickle cells do not go through the kidney very well. They can have a risk factor for stroke because as those sickle cells move along the body and they go doo, 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 and they move along, they get caught on curves and things in our body. And as more and more sickle cells get caught, they form a clot. That clot breaks off, causes a stroke. Heart dysfunction, same thing. Leg ulcers because they can't get the blood supply down to their legs. Sepsis because it does increase their risk of infection. Newborns, our babies, are going to be at higher risk for premature birth, small for gestational age, plus they can inherit the crisis. So, if you think about the red blood cells that are carried, our oxygen is carried on our red blood cells. If we have a sickled red blood cell, that sickled red blood cell is also going to our baby. If it's sickled, it can't carry oxygen. If it can't carry oxygen, it can't make that baby good. So our focus is just treatment, prevention of those crises. Sickle cell anemia, more on that. Pregnancy is considered high risk if they have sickle cell anemia. If a crisis occurs, we want to look at that, the CBC, because we're looking specifically at that red blood cell. We're also looking at their white blood cell count, because sometimes infection can cause them to sickle. So we're going to look at that. A lot of times they need blood. So we're going to cross match them. We're going to look at their ABGs to see exactly what their oxygen levels are. We're going to give them lots of fluid. Sickle cell anemia is very, very painful. These sickles go through, your joints and things, and when they go through, they get caught, and it can be very, very painful, one because of hypoxia for a lot of reasons. So we're going to support these patients, make sure that they are very, very healthy prior to pregnancy. Okay, so we're going to talk a little, why is that not working? We're going to talk a little bit about, actually I'm not going to talk a whole lot about asthma. I just want you to know that every mom can have asthma. Just make sure that, mainly the thing that we're going to look at is, what does an asthma attack look like, and what is our goals? Asthma attacks is just difficulty getting air in, bronchial constriction. So we're going to manage that asthma as best we can, make sure that they have their inhalers, make sure that we're looking back at how we can help them to manage their asthma. So just make sure we're looking at all of these things. I'm not going to read all this to you. Just go back and take a little quick look at it. Epilepsy, I won't take a lot of look at this either, but a lot of epileptics have to take anti-epileptic medication. Anti-epileptic medication is tetragenic to the fetus. So many times we have to look at things for other alternatives to manage their manage their seizures. So we want these moms to also come in and look at preconception to minimize the risk to her and minimize risk for the baby. Because we got to look for something different. We can't give them what they have. These moms specifically have to increase their folic acid. Moms that have epilepsy are at higher risk for neurotube defects, so we have to increase those. We're going to look at those. So these moms are going to get ultrasounds. We're going to request, they don't have to do it, but we're going to request that they get screened for the maternal serum alpha-fetoprotein levels to look for that. So we're just going to look for all those kinds of things. As far as nursing considerations, make sure that you talk to them that they have to come for their prenatal visits. You will be surprised how many people do not do prenatal visits. They come in at delivery and they've never seen a doctor. So it's important that they come for all their prenatal visits, that they make all those prenatal visits so we can keep an eye on this mom. She needs to make sure she's eating that diet high in folic acid, get plenty of rest, avoid stress, make sure she's getting all of her support that she needs at home. So other things that we're going to talk about is anything that is complicated with infectious diseases. So I'm going to talk a lot about infectious diseases, and it's called TORCH. It's kind of long, so now might be a good time to take a break and then come back. So take your break, come back. Okay, so prevention is the best treatment. So important terms that I want you guys to realize is immunoprophylaxis. That means prevention of the disease by giving you active or passive immunity. That is vaccinations. How can we prevent things from happening before exposure? Now, how are things transferred? Perinatally means throughout pregnancy. Vertical transmission, transmission of infectious agents from mother to child during pregnancy, childbirth, or breastfeeding. Typically, baby and mom's blood does not mix except at delivery. Not always. It can, but that's typically when it mixes. Now, we can give suppressive therapy where we can suppress the disease, but we can't cure it. We'll do that sometimes in like our HIV patients. We want to look at viral load. So if we got a mom, a viral load doesn't really necessarily even have to be HIV. But if you get a virus, you have what we call a viral load. The higher the viral load, the increased symptoms. The lower the viral load, the less symptoms that you have. So if you are well and healthy, you shouldn't really have a viral load at all. But if you have COVID, we would look at your viral load and see how high that viral load is. And the higher that, the more symptoms that that person's going to be exhibiting. Okay, so TORCH. TORCH stands for toxoplasmosis, other, rubella, CMV, and herpes simplex virus. Those are the 5 things that it stands for. Other pretty much just encompasses everything else that we can think of. So all of these are tetragenic. All of these cross the placenta. All of these can affect the fetus and can determine, where in gestational age did they develop the infection. Because remember, that first 1 to 3 months is the most critical. So if you get a baby that mom gets it in that first 1 to 3 months, that's going to be way more critical for the baby than if mom gets it a week before she delivers. The baby is pretty much formed at that point. So many of these babies, many of these things, and we're going to talk about each one, but many of these have intrauterine growth restrictions. So our babies are going to be they're going to be struggling. Microcephalic, which means the brain is developmentally small. That does not improve. They have a small brain, and it doesn't mean once they're born, their brains are going to go to normal. It's not typically what happens. Hepatosplenomegaly just means a large spleen and liver. That usually can complicate things for us. That can increase the risk for, bilirubin problems. Rash, thrombocytopenia, central nervous system findings, cognitive impairment, hydrocephalus. Hydrocephalus just means a large head. They have extra fluid in the ventricles of the brain. Jaundice, hearing defects, chorioretinitis, all of these, none of these are good. None of these are good. None of these deliver good outcomes. So all of these cause these. So it's not good. A lot of these, if mom gets these early on in pregnancy, mom might go ahead and just have a spontaneous abortion. Some of these babies will be born stillborn. Some of these babies will be born prematurely, along with having all of these complications. So the number one thing that we can tell parents is prevention, prevention, prevention. Get your immunizations. Make sure that you're healthy prior to going into your pregnancy. So how do we diagnose these? Serological tests. We basically just draw blood, and we can draw blood for all of these titers, and we can do cultures. So a lot of these are blood tests. This is for hepatitis B. But cultures, we can draw for CMV and herpes simplex. We can do pap smears, ultrasounds. We're going to do ultrasounds. We're looking for the fetus not growing like it should, or we're looking for a defect that we're going to see on those ultrasounds. Okay, so toxoplasmosis is our first one of the TORCH. So this is Toxoplasmata godati. I don't know how to spell that, but I've always just called it toxoplasmosis. It is transferred through undercooked meat. So these are moms that are dealing with undercooked meat, and they don't wash their hands good, and they ingest it. Unfiltered water, contaminated soil, cat feces. So if you got a mom that gardens, she needs to be wearing garden gloves outside to garden, because cats poop outside. So make sure that she's using all of that. Usually these moms do not have any symptoms, so it's very difficult to diagnose. So it's something that maybe, baby is born with something wrong, and we start looking and we find that mom had toxoplasmosis. So a lot of these babies are born with congenital toxoplasmosis, and a lot of times they will present with chorioretinitis, which means that they have inflammation of the retina of the eye, and hydrocephalus with increased ventricle brain. Decrease the risk of the infection. How do we tell moms to decrease it? Don't change the cat litter. Wear your garden gloves, wash your fruits and vegetables, all that good stuff. Hepatitis B. So this is TORCH. This is the O. This is the other. So hepatitis B is transmitted by blood and body fluids. We have majorly decreased it by giving the hepatitis B vaccines, a series of 3. Most of our moms will get tested to see if they're reactive to Hep B. If not, we would highly, highly, highly encourage her to get that. Get it before she becomes pregnant. But they should be screened early in pregnancy for hepatitis B. If the mom is pregnant, here's the difference here. If the mom is positive, she has Hep B, that baby needs to get an immunoglobulin to protect that baby right at birth. And the baby should still get their Hep B vaccine. And they need to get all 3 doses of that Hep B vaccine. Hopefully if mom has Hep B, hopefully giving the immunoglobulin will prevent the baby from contracting Hep B. Syphilis. We had a baby born not long ago that had congenital syphilis. And it's a bacteria. It crosses the placenta and it has 3 stages. Many moms don't know that they have it. They come in, that's why we monitor for it. That's why we look for it. These moms are at increased risk for spontaneous abortions, fetal demise, intrauterine growth restriction, non-immune fetal high drops, where the fetus just doesn't develop. This is usually a fatal condition. Preterm birth, congenital infection, and death. So, most babies that are infected are asymptomatic at birth. What we might see is their liver and spleen might be large. If their liver and spleen is large, usually they're going to have jaundice. They might have snuffly noses, long bone abnormalities, but they may develop more things as they start to grow and develop because of this. So we're going to screen for it. The test that we use is an RPR. I don't even know what it stands for, but RPR or a VDRL. So those are the tests that we test for it. If mom tests for it early on in pregnancy, we're going to treat it with antibiotics, so it's very easily treated, but we have to catch it. That's why every mom that first prenatal visit will get lots and lots of prenatal screens. Varicella or chickenpox. So this is chickenpox. Most of everybody has been vaccinated, but if you get a mom that has not been vaccinated, it's more risky if mom gets it during the 2nd trimester, because that's when everything is forming. These babies are more born with low birth weight, scar-producing skin lesions. That means they're going to have lots of skin lesions and they're going to have scars all over their bodies. Limb hypoplasia, which means that limbs would mean arms and legs don't develop. So maybe they develop the buds, but they don't develop the full arm. Maybe they develop part of the arm. Maybe they have no use of the hand. They might have contractures. They might have damage to their ears, eyes, and central nervous system. So if they've been exposed to the virus and they don't know if they've had chickenpox, they need to have a serology done to see if they have antibodies. And if they have, maybe there's something, we can give them to help prevent that from happening. But basically, the only thing we can do is prevent. Make sure mom has the vaccine. Rubella. This is the MMR. The rubella is measles, mumps, and rubella. That's the last R. It's the German measles. Most of the time, mom don't have any problems. Mom's just got a low-grade fever, rash, doesn't feel good. Lymphadenopathy just means lymph nodes are swollen. General fatigue, not much. Baby, on the other hand, can have severe things. This baby is at risk for spontaneous abortion, stillborn, preterm delivery, and a lot of times these babies have congenital anomalies. So these babies will be born with problems with their limbs. They will be born with things wrong with their bodies. Their hearing might be, maybe they're blind. Lots of things that can be wrong with these babies. So it's imperative that these moms get that. Can they get this vaccine while they're pregnant? No, no, and no. It's a live virus. There is no cure. The treatment is just support the baby and support mom. The best treatment is prevention. Get your MMR before you get pregnant. If you have a rubella titer and it says you're immune, you're good. But if you're not immune, after that baby's born, you need to get your rubella, because the next pregnancy you could get, exposed to rubella. A lot of people, you've seen a lot of push for a lot of parents not to vaccinate their children. If the children aren't getting vaccinated, we will have a resurgence of many of these viruses and bacteria that we have eradicated over the years. But now that people aren't getting vaccinated, they're going to come back. And when they come back, we're going to see these problems with our babies. So just make sure that we're educating our parents the best that we can. Cytomegalic virus, moms usually don't know that they have it. If they do have it, it's very mild. Most of the time, people have had CMV and they've had it when they were children. But it's transmitted through infected body fluids. So cough, sneeze, anything like that. It can be passed to the fetus. It can result in very, very severe defects. hearing loss, microcephaly, seizures, small for gestational age, lots and lots of things. There is no vaccine. There is nothing that we can do to treat this one. There's no cure. Prevention, prevention, prevention. Don't be around somebody, little kids, if they're sick. You don't know if it's CMV or not. So just make sure that you stay on top of those things. Herpes simplex, that is herpes 1 and 2. It's spread by direct contact. Symptoms, they're going to have those painful lesions in the genitalia area. Now, a lot of times this virus goes dormant, especially with certain medications that we give. We give like antiviral medications like acyclovir, and a lot of times that can keep it dormant so they don't have those lesions. Now, if baby's exposed, baby can get it through the birth canal, and baby can be born with congenital herpes. They can get herpes in their eyes, they can get herpes in their lungs, they can get herpes on their skin. So it's important that we really treat these moms. If mom has active lesions, this is important to know. If mom has active lesions, we're not gonna deliver vaginally. We're probably gonna deliver by a C-section because we don't want to risk the baby coming through that canal. Okay, sexually transmitted diseases. Now we're moving on. We've done torch. We're going on to STDs. So STDs, these are usually through sexual contact. This is going to be your Hep B, your syphilis, your herpes, chlamydia, gonorrhea, genital warts, trichomonas, HIV, all the good jazz. All of these are reported diseases. So if you come into the doctor and the doctor tests you and it's positive, that test result has to get sent to the state. These are all reportable to the CDC. That's how we come up with our statistics. That's how we know how many people have active disease. That's how we know what's going on in our counties and what's happening. So all of these are reportable. Chlamydia, it's the most common. Most women don't have any symptoms. So they usually have delays in treatment and diagnosis because they don't have any symptoms. But with this, a lot of the moms can get pelvic inflammatory disease. Sometimes they can and the pelvic inflammatory disease just means that they got an infection in the fertility organs. So sometimes they can get that in their fallopian tubes. It can cause scarring of the fallopian tubes. It can increase their risk for ectopic pregnancies. But if mom gets it while she's pregnant, it can increase her risk for spontaneous abortion, premature rupture of membranes, preterm labor. Mom can contract it while she's pregnant. So mom might get all of her lab work drawn at 12 weeks and it's negative, and she comes back at 38 weeks right before. We usually do all the lab work again at 35 weeks or 36 weeks when they come in, and we do all this lab work again to make sure that mom hasn't contracted anything since the beginning of pregnancy. It's treated easily with antibiotics. Gonorrhea is pretty much the same. It has the same kind of stuff. Ophthalmic neonatorium just means that a lot of times babies, when they come through the birth canal, if mom has gonorrhea or chlamydia, they can get what we call ophthalmic neonatorium, which is infection of the eyes. That's why every baby that is born gets the erythromycin or one of the antibiotics, ophthalmic antibiotics, to treat anything that comes through there. So all moms will get a culture, a vaginal culture for chlamydia and gonorrhea at prenatal, and they'll get it again at 36 weeks. Treat it, antibiotics. HPV, this is human papillomavirus. We're seeing this has been decreased dramatically since the HPV vaccine. So I highly, highly encourage everybody to get the HPV vaccine because our cervical cancer rates have plummeted. So that's why the pap smears have changed now to 21. Used to it was when you became sexually active, because the more sperm that interacted with the cervix, the more the cervix would have changes. And so now with the HPV vaccine, we're seeing that we don't even need to do pap smears till they're 21 because we have pretty much taken care of it. So it's great. It's the most common STD that we see. It's spread by skin-to-skin contact. It was the #1 reason that we had cervical cancer. We diagnose it through our pap tests. It can pass the HPV during the birthing process. So if mom had active genital warts during delivery, we may choose to do that C-section. But treatment depends on a lot of different things. Sometimes we can just burn them off. Sometimes there's medications that we can give, but we highly encourage everybody to get the vaccine to help prevent. The vaccine is now even available. They increased the people that can get it. Used to, we only gave it to, they were 13-year-olds in 6th grade is when we started giving the HPV vaccine, and it wasn't indicated for older individuals that were already sexually active or had HPV. Now we're finding that anybody 45 and younger, we're recommending getting the HPV vaccine. So we're finding that it even works if you have HPV. It is suppressing the disorder. So that's great. Trichomonas is just a vaginal delivery, vaginal kind of protozoa that we can get in the vaginal canal. It can transmit to the baby through delivery, but it's probably rare. Probably wouldn't worry about it. This is where we get large amounts. It sounds kind of gross, but we get large amounts, kind of foamy, green, fishy smelling vaginal discharge. Usually a lot of itching. It's odorous, painful sex. And so a lot of times that's what's going to bring him to the doctor. And so we have to do a culture, look at it. These are a few things it can cause, and we treat it with Flagyl, which is metronidazole. So it's easily treated too. HIV, human immunodeficiency virus. It's transmitted through unprotected sex, sharing needles, IV use, tattoos, anything where there's a mixture of someone else's blood into your blood. Many of these people might not know how they got infected, so we don't really know the cause of where it came from, but this can be transmitted to their fetus during childbirth or during breastfeeding. So moms that are HIV positive will be contraindicated to breastfeed. We don't breastfeed them. Now, usually your HIV positive moms are going to be at higher risk for, I'm going to move my face, higher risk for domestic violence and homelessness. So just be aware of that kind of stuff. We did have a mom that came up that was homeless, and she was 27 and had multiple, like 10, 12 children already. And it was a very sad case. So I don't think she was HIV positive, but just remember that is, that is a population that we will be dealing with, because sometimes they're, selling services for food, selling services for, a place to live, just to keep themselves going. So just remember those kinds of things about the people that are out there. Many times we go ahead and start them on treatment. The moms will get started on treatment, and it helps to decrease the progression of the disease. And sometimes we can prevent the transmission to the baby with the correct medications if we use the correct medications. So the best way to prevent transmission, identify that they have HIV before pregnancy, and then start treatment early on in pregnancy. And then no breastfeeding after pregnancy. Intimate partner violence, we're seeing this more and more. World is stressful. We're seeing a lot of intimate partner violence because of stress. A lot of things are, a lot of factors in the way that we live in today's world. So pregnancy can be complicated by that. So just make sure that most of the time our abuser is just wanting control or power over the partner. So just be aware of that. But sometimes the abuse can be different types of abuse. It can be in any culture, any relationship. Just be aware that it's out there. A lot of times intimate partner abuse may not start until they become pregnant, and many times it does escalate during pregnancy and right after pregnancy, just because of the increased stress level around the home. So we have to look for moms, be sure and watch them for hemorrhage, abruptio placenta, intrauterine growth restriction, preterm labor, all of those kinds of things we're going to monitor for. So we've kind of talked about that. I just want you to read over this and just be aware. I think you've talked about this in other components of your teaching and what we've been teaching you, but just be aware of this cycle. It is a cycle. It is real. It does happen. So just be aware of it. As far as screenings, we're going to screen them starting on day 1 when they come in for the first prenatal visit. So routine screening on every woman. So we want you to be aware of the barriers that they can come in with. Make sure our moms are safe. A lot of times we have safety plans. Be kind of astute if you have a man that comes in and refuses to leave the room or refuses to leave the female by herself. A lot of places now have places in the bathroom where put an X on your urine cup if you feel like you are being, you're scared to go home. Sometimes the abusers will actually follow them into the bathroom. So that would be a red flag that I would be looking for. So just be looking for some of those kinds of things and help them through those situations. So I'm not going to really talk to you about that, but just look through those kinds of things and be aware of those. As far as age-related concerns that we're going to see with pregnancy, typically our childbearing years are between the ages of 15 and 44. That's typical. Now, 15 is going to be considered young, 44 is going to be considered geriatric. But women can become pregnant anywhere between 9 to 56. So just be aware there are higher and lower things there. But pregnancy that is younger and older does carry a higher risk of morbidity and mortality on moms and babies. So just be aware if you have a mom that comes in older and is pregnant, or a young girl that comes in, there's a higher risk for mom and baby in that. Okay. So adolescent pregnancies, these are going to occur in moms that are 19 years or younger. They are more likely to have preeclampsia, so we want to make sure we're monitoring their blood pressure a little bit closer. Their babies are more likely to be below normal birth weight. They're likely to have premature labor, and they have a higher mortality rate in their babies. So clinical manifestations, a lot of times your pregnant teenagers are embarrassed or they don't want to tell their parents, and so they don't seek that prenatal care until that 3rd trimester, until they can't hide it anymore. And then by that point, we may have missed some of the very important things that we needed to be looking for. So treatment, again, is prevention, getting them out there, teaching, social networks, all the things that we can do to help teach these young women how to care for themselves. Just I'm not going to read all that to you, just be aware of all that kind of stuff. Make sure you're talking to them about nutrition. Many times they don't eat the best, they don't drink the best of things, they don't worry about doing extracurricular activities because they're young and they're healthy, and so they don't think about those kinds of things. Again, very non-judgmental attitude though towards our young moms, because we got babies coming into the world and they're going to have to take care of them. Later in pregnancy, these moms have an increased for assisted reproductive techniques. Usually this is going to be your fertility moms. They've had in vitro, they've had something else go on. If they're over 35, you can just see how much it increased on what kind of complications they're going to have. So all of these are complications. All of these are real. All of these are things that we need to monitor for. So every time that mom comes in, it's going to be really important to make sure you monitor that mom closely, ask the important questions, look at their urine, look at their blood pressure, look at all of the things that could be wrong. These moms really need to have the alpha-fetoproteins drawn to make sure we know what we're dealing with. Make sure they have all their screenings. Many of these moms that become pregnant later in life, you have a 45-year-old mom that's pregnant, she's more likely to have developed type 2 diabetes already. She's more likely to have developed a cardiac problem, a coronary artery problem. She's more likely to have also been diagnosed with chronic hypertension. So that's going to just increase the risk factors for this mom. So if mom is 40, over 40, 45, wanting to get pregnant, we need to make sure that she does preconception teaching. Make sure that she's aware of what's going to go on. Make sure she understands complications and what kind of conditions there are. It does increase her risk for chromosomal abnormalities because the eggs are a little bit older, so they may not have the correct combination in there. So nursing care, non-judgmental, just make sure that you're encouraging them, you know, this is probably a big time in their lives, and they're scared. So just make sure that you are supportive, and make sure that you're giving them the correct advice that they need at the time. And that's it. Thank you.